Welcome to this Clinical Explainer. Today we're jumping straight into the high-pressure world of obstetric emergencies, mapping out the exact physiological variables and hard lab cutoffs that completely shift our management pathways. Because, let's face it, in high-stakes obstetrics, generic knowledge just doesn't cut it. We really need to master those granular, subtle boundaries that dictate survival. Here's our roadmap for today. We're systematically navigating through 4 core modules, starting with hypertensive disorders and timelines, then acute third trimester bleeding, moving into labor dynamics and arrest, and finally tying it all together with clinical reconciliation.
All right, kicking things off with Module 1, Hypertensive Disorders of Pregnancy, where we're mapping the endothelial dysfunction axis.
Now, what's incredibly important here is how strictly defined these diagnostic boundaries are. Gestational hypertension is strictly a blood pressure of 140/90 or higher after 20 weeks, no proteinuria, no end organ damage. Preeclampsia brings in that critical proteinuria threshold, right? Greater than or equal to 300 milligrams in 24 hours. But the absolute pivot in management? That happens when we hit severe features. We're talking blood pressures crossing 160/110, platelets dropping below 100K, transaminases doubling, or the sudden onset of severe right upper quadrant pain or visual disturbances.
So, why does this matter? Well, the manifestation of those severe features fundamentally alters our timeline. With stable preeclampsia, you can comfortably lean on expectant management, modified bed rest, with a mandatory delivery threshold strictly at 37 weeks. But the second those severe features develop, that threshold shifts drastically back to 34 weeks. And if it's complicated by eclampsia, HELP syndrome, or any maternal fetal instability, you are forced into immediate delivery to prevent a cerebral hemorrhage or maternal death.
Let's put this into practice with a quick clinical fork. Picture a patient at 33 weeks gestation. She presents with a blood pressure of 158/98. Suddenly, she develops severe, persistent epigastric pain, and her transaminases jump to 140. Based on the exact parameters we just covered, what's your move? Do you observe, or do you deliver?
If you're thinking about conservative bed rest here, honestly, don't. It is a massive diagnostic trap. The clinical picture completely forces immediate delivery. That epigastric pain and those elevated LFTs confirm she has crossed into severe features territory, even if her BP hasn't quite hit 160/110 yet. Immediate delivery is mandated. Concurrently, you have to initiate a continuous magnesium sulfate drip for neuroprotection and seizure prophylaxis. And you've got to aggressively control that blood pressure with IV labetalol or hydralazine, aiming strictly below 160/110.
And this brings us to a really critical clinical variance box, magnesium toxicity. When you start that high-dose magnesium drip, failing to continuously check deep tendon reflexes is a huge liability. Toxicity presents as a hyporeflexic state, and if you miss it, it can rapidly deteriorate into fatal respiratory paralysis. The absolute management pathway shift here is immediate administration of the calcium gluconate antidote. Moving right along to Module 2, third trimester bleeding. We really need to analyze these acoustic anatomical forks because out here, survival is dictated in a matter of minutes.
We absolutely have to anchor on the painful versus painless distinction. Placenta previa, that's painless. Bright red bleeding, the placenta is implanted right over the internal os, usually without immediate fetal distress. Contrast that strictly with abruptio placentea, painful, dark bleeding with severe uterine hypertonicity. That's a retroplacental clot, often driven by maternal hypertension or cocaine use, leading directly to fetal hypoxemia and late decelerations. And don't forget vasoprevia, painless bleeding right at amniotomy, causing rapid fetal exsanguination, which you'll see as profound bradycardia or a sinusoidal tracing.
Notice the specific timing of a late deceleration. That visually apparent gradual decrease in the fetal heart rate has its onset, nadir, and recovery occurring definitively after the contraction. That late nadir, it is literally the acoustic hallmark of uteroplacental insufficiency, which is so frequently driven by that retroplacental clot of an acute abruption.
So, let's test this with a trauma presentation. You have a patient at 35 weeks coming in after a high-speed motor vehicle collision. She's got abrupt dark vaginal bleeding, severe back pain, and the tracing is showing repetitive late decelerations. How are we managing this?
In a chaotic trauma setting, it is so incredibly easy to get sucked into the reassuring tracking loop of expectant management and fluid resuscitation. But you have to remember that fails to address the actual physiology. There is an expanding retroplacental clot and active maternal fetal hemorrhage happening. You must completely bypass that fluid resuscitation trap. Acute, moderate to severe abruption with fetal distress is an absolute indication for an emergent cesarean delivery, period.
Which brings us to a massive variance box, the low-frequency visual diagnostic trap. There is an absolute contraindication against performing digital cervical exams in undiagnosed third trimester bleeding. If you do a digital exam on an undiagnosed placenta previa, you can trigger a massive, fatal fetal-maternal hemorrhage. You absolutely must rule out placenta previa via ultrasound first, every single time. No exceptions.
Okay, Module 3, Labor Dynamics. We are shifting from acute bleeding over to mechanical intrapartum dynamics, specifically looking at strict quantitative decision boundaries.
To diagnose any kind of labor abnormality, we have to know exactly when the clock starts. The active phase of the first stage of labor begins strictly at 6 centimeters of cervical dilation. Once she hits 6 centimeters, the arrest parameters are live. We are looking for either 4 hours of no change if contractions are adequate, or 6 hours if they are inadequate.
This table is absolutely key for separating protraction from arrest. Active phase protraction? That's just slower than expected change due to inadequate uterine force. It buys you time to use oxytocin and amniotomy. But active phase arrest? That is a hard stop. No change for 4 hours despite adequate contractions, strictly defined as greater than 200 Montevideo units on an IUPC, or 6 hours with inadequate contractions. Active phase arrest is an absolute indication for a C-section.
Let's look at a classic stall scenario. You have a patient at 7 centimeters dilation, 0 cervical change for 4.5 hours. Her internal pressure catheter is tracking continuous contractions at 240 Montevideo units. What's the precise diagnosis here, and what is your immediate next step?
Let's just break down the math. She's at 7 centimeters, so she's firmly in the active phase. Contractions are at 240 MVUs, definitively adequate, and she has passed that 4-hour threshold with 0 change. Because those contractile thresholds are fully met, the diagnosis is definitively active phase arrest. The only correct resolution is to force immediate cesarean delivery.
And here is the trap, the oxytocin titration decoy. Inappropriately pushing more oxytocin when an arrested active phase is already established, when those 200 MVUs are already met, is a severe clinical error. It wastes critical time, does absolutely nothing for the cervix, and massively risks fetal hypoxia. Do not push oxytocin against an arrested active phase.
Finally, Module 4, Clinical Reconciliation. Let's integrate these isolated systems and evaluate how we balance competing maternal and fetal risks when everything is happening at once.
Before we do, let's rapidly catalog the parameters that are so easily missed. Number 1, doing a speculum or digital exam in a bleeding patient before an ultrasound. 2, brushing off a preeclampsia headache as just a tension headache. 3, forgetting to check deep tendon reflexes on a magnesium drip. And 4, pushing oxytocin during an active phase arrest. These are the exact moments where clinical consultants have to step in and stop a catastrophic outcome.
Okay, the ultimate test, a final integrative scenario. We have a 36-week patient. BP is 165/105. 3+ proteinuria, severe headache, right upper quadrant pain. At the exact same time, she is laboring at 6 centimeters dilation, but hasn't changed for 5 hours, despite an IUPC reading of 220 MVUs.
We have competing risks all over the place here. Neurologically, her severe features put her at imminent risk for an eclamptic seizure. Start a continuous magnesium sulfate drip immediately. Cardiovascularly, that 165 systolic pressure is a stroke risk. Push IV labetalol to drive it below 160/110. Obstetrically, she's at 6 centimeter, with 5 hours of no change despite 220 MVUs. That is strict active phase arrest. You have to simultaneously stabilize that maternal endothelium medically while immediately bypassing labor for a surgical delivery. Because at the end of the day, mastering these granular boundaries ensures you don't fall for reassuring decoys when seconds actually count. In high-stakes obstetrics, subtle variables don't just shift management pathways, they dictate survival. So the real question is, are you tracking the right parameters?